Hello, everyone, and welcome to the UHN Foundation COVID-19 Q&A live stream. I'm Christian Coté, host of the UHN podcast Behind the Breakthrough, winner of the 2022 Canadian Podcast Awards for Outstanding Science Series. We're glad you could join us and grateful to you, our family of supporters who've been so generous these past few years throughout the pandemic. So a big thank you on behalf of the UHN Foundation and all of Team UHN. In today's episode, the latest on what some are calling the season of the tripledemic, with COVID-19, the flu, and RSV hitting us all at once. Also, when to get your vaccine booster shot and how to protect you and your family as we enter the holiday season. Of course, a little later in the broadcast, we'll get to your questions. And today on the broadcast, we're glad to be joined by Dr. Alon Vaisman, UHN Infection Protection and Control Physician. Welcome, Dr. Vaisman.
Thank you for having me.
Let's get a big overview, if you don't mind, Alon, off the top in terms of COVID-19 in Ontario. I understand we've just emerged from the 7th wave, hard to believe. So where are we at in terms of the most prevalent COVID strain that's circulating in the province, its severity, and its spread?
So what's interesting in terms of what we're observing now with COVID waves is that we're not seeing the big spikes like we were previously in the 2 years prior. Ever since Omicron showed up in December of last year, 12 months ago, we had the very big spike in January, but since then we've had smaller spikes, smaller waves that have kind of persisted. So we've never really gone down to a very low number like we did previously in the summer. So April, June, August, September, October, we're seeing up and down waves, low level amounts of COVID, slightly going up, slightly going down. And this has resulted in hospitalizations and illnesses with each wave. And this is due to the fact that Omicron is quite infectious. So since it's arrived, we've seen continuous infections throughout the population. It's making its way through. A large number of individuals here in Ontario have been exposed and infected by COVID. Perhaps 70–80% of all of Canadians have picked up COVID by this point, perhaps even larger. And in terms of the variants, we saw that the various Omicron variants came through Ontario, starting with BA1, 2, and then 4, 5 was the most recent. And now we're seeing an increase about 15% in total of BQ1. And what this all means is that we're just going to see more and more mutations, various Omicron mutations at this point, that will to some degree lead to continuous transmission between people for the foreseeable future.
Okay, and we'll get into some protective measures, but first there's this complicating factor at play right now, right? The onset of flu season and the emergence of what's called RSV, this respiratory virus that's most prevalent amongst children. You said that the flu and RSV are not new. So what is it about this particular point in time that's got people saying, we're in the midst of this, what's called a tripledemic?
So throughout the last 2 seasons, when we expected flu and RSV to arrive, there wasn't a substantial wave like we saw before 2020. And when we expected is December, January, February, essentially the winter months. So before the pandemic, we would see this very predictably during those months, flu and RSV and many, many other viruses we don't test for. They arrive, they affect adults, they affect elderly individuals, they affect children, and they cause, unfortunately, some degree of morbidity and mortality in those populations. Then, during the 2 years of the pandemic, 2020, 2021, in those winters overlapping up until earlier this year, there was very little activity for a whole variety of reasons. A lot of it has to do with the fact that there was a lot of restrictions in people's activities, travel restrictions, masking, distancing, hand hygiene. A lot of things went in to prevent COVID transmission, also prevented flu and RSV. Now, this time around at the end of 2022, when most of those restrictions have been lifted, a lot of those viruses are returning, especially travel restriction. We're seeing so much travel, and hence why the flu wave that was seen in the Southern Hemisphere in the summer is now arriving here in the Northern Hemisphere. And that is why we're seeing a lot of RSV and flu activity this time, even more than what we saw in previous years before the pandemic, for a whole variety of reasons.
Okay, so talk to us then about the pressures of this perfect storm of the tripledemic, where our healthcare system is contending with all 3 of these, the COVID-19, flu, and RSV.
So the COVID-19 activity isn't so high right now. It is putting additional pressure, but the exceptional pressure is from flu and RSV. At the moment, and if we look back to October, November, then December, the most amount of pressure is put on is the pediatric system in Ontario. So flu and RSV are at a higher proportion affecting those children right now, leading to more morbidity than previous years. And the pediatric system doesn't have as much flexibility as the adult system as we've had throughout the pandemic. because the capacity is just smaller, happens to be that way in Ontario. As a result, the pediatric system, especially with the increased number of cases of patients needing to be hospitalized, unfortunately has had overcapacity issues, long wait times, cancellations of surgeries, transportation of children between hospitals in Ontario. So the biggest burden of this tripledemic, so to speak, has been on the pediatric side. Thus far, it hasn't been on the adult side in the same way. But going into the late December, early January, we do anticipate that flu and RSV are going to make their way to adults, as has seen in previous years, where children are infected and followed by adults. So that is something we anticipate during the next 8 or so weeks, to see more flu and RSV cases in the adult population.
I read one explanation with regards to the surge in RSV this season, where someone sort of thought the underpinnings or felt the underpinnings of this were something called immunity debt. Can you explain what that means and how much stock you put in that theory?
So it's a term that has been used in the past and been popularized the last few months. There's been a lot of misunderstanding around what was it referring to and why is it being used. The important thing to recognize is that the overall concept of immunity debt isn't so much that an individual who, let's say, was masking and distancing the last few years and not exposed to viruses is now somehow more susceptible because their immune system is weakened by those things. That's not the correct way to think about that, and it doesn't seem to be accurate. It's important to think about immunity debt as more as a population level. And quite simply, all it means is that because over the last 2 years, flu and RSV exposure has been quite low on a population level, when those viruses return now in this winter, we're seeing a higher proportion of kids being affected by it than before. This could be that on a population level, the immunity was not as high because certain kids at certain age groups were not infected in 2020 or 2021, but now they are. That is one explanation for why there is more cases of RSV and flu among the kids. So that's why that term is being used. That's one theory about what's been going on lately.
All right, we have a lot of parents in the audience. So if you don't mind, it would be nice to get a primer actually in terms of flu, RSV, COVID. If you could perhaps compare the incubation periods and periods of infectivity.
Sure. So there's a lot that overlaps between COVID, flu, and RSV, but one thing that parents should keep in mind is that there isn't as much pre-symptomatic transmission with flu and RSV as there is with COVID. That was one of the reasons why the COVID pandemic was so exceptional, among others, was that even before somebody has symptoms, they could be transmitting COVID. With flu and RSV, that's not so much an issue. When you transmit flu, you usually do it within the first 5 days, similar with RSV, perhaps in the first 8 days of you having symptoms. And generally speaking, for flu and RSV, as long as you're symptomatic, that's when you're going to be transmitting the virus, especially in the first few days. So that's the first 3 or 4 days, usually with flu. That's when most of the transmission happens. In terms of incubation, flu has a very short incubation period, between 1 and 4 days, perhaps on average around 3 days. And RSV is a little bit longer, perhaps up to 5 days. In other words, if you have the flu and you expose somebody else, they will on average develop symptoms about 3 days after you expose them. For COVID, it was up to 5 days in the beginning of the pandemic, now closer to 3 or 4 days. So it's perhaps a little bit closer. So the periods are a little bit different for flu and RSV. Important to keep in mind when you're thinking about arranging get-togethers or thinking about if you've had exposures, last contact with family members or children.
Is there anything, well, perhaps just if you don't mind, go through them for parents out there. What are the symptoms to be looking for with their children if they perhaps are contracting RSV?
Yes, that's a great question. Flu, RSV, and COVID have symptoms that are more or less indistinguishable from one another. There is the feature of COVID that some patients still experience of having loss of sensation of smell and taste, which is not typically a feature of flu or RSV. Outside of that, the same symptoms apply to all three, which is runny nose, sore throat, perhaps headache, fever, and if it's very severe, shortness of breath, cough, of course, and perhaps even a productive cough. Those are all features that overlap between the three. If a parent has a child who experiences those symptoms, the reasons to go to hospital will be the same in all three cases. If the child is not doing well, not eating well, not breathing, of course, having high fevers, not able to do their daily activities, those are all reasons to go to the hospital, regardless of the cause in terms of those three viruses. And in terms of treatment, for most children, there won't be any treatment offered for kids who are not coming into hospital. If a child is sick enough, unfortunately, to come into hospital, there are treatments available for flu and COVID For RSV, it's not as readily available. It's generally available for kids who are very immunocompromised. So that's the important thing to keep in mind. We haven't managed flu or RSV for a long time, for about 2 years. So it's important for parents to think back to how things were before the pandemic. But again, keep in mind there are red flag symptoms for all three viruses.
Let's get into preventive measures. I see where the Hamilton Wentworth School Board recently moved to mandate indoor masking for schools in that district. How effective, in your opinion, is masking to reduce the spread of both RSV and coronavirus?
As far as we know, for the adult population, it's fairly effective, and it has been the standard of what we use here in hospital settings to prevent transmission between staff and patients to staff. So a patient who has flu and RSV, staff will look after them with a mask. That's what we've been doing for decades, essentially. So in adult populations, we know that's effective. In terms of what do we do in the general population outside of hospitals, that's a little bit less clear of how effective masks are. Presumably, they are effective on a population level as well. When it comes to schools, it's a fairly contentious issue. The evidence is not as strong to suggest that masks being protective among children. However, I would say that it's a decision that's up to parents to decide whether they want their kids to wear masks, especially kids who are immunocompromised, who have immunocompromised individuals in the family. It adds another layer of protection, just recognizing we don't have as much confidence or knowledge about how effective they are in that setting. Mandates are a whole other question. It adds the other level of policy and whether mandates are followed and how you enforce a mandate and whether there's punishments associated with it. So that's a little bit of a trickier question. I'd say that mandates probably not going to have the same effect, especially in schools, as they had in the past for COVID. But of course, individuals can make decisions for themselves. Parents can make the call for their own children, or kids who are old enough can also make the decision about whether they choose to mask or not.
On the COVID-19 vaccine front, earlier this fall, the bivalent vaccine became available. Can you first explain how it differs from the original vaccine?
So the bivalent vaccine, which has now been available for several months here in Ontario and across Canada, differs from the original in that it contains two strains of the virus. The original strain plus a more updated Omicron strain, which can be updated in the future again. The idea behind it is that because Omicron showed up a year ago and was fairly evasive compared to the previous strains in terms of its ability to evade the effect from the vaccine, adding another strain, a more updated strain, hopefully makes it a little bit easier, makes it a little bit more effective against COVID. And the evidence does show that it is more effective, but it's important to recognize that with all mRNA vaccines or all vaccines developed against COVID so far, the effect is not going to, unfortunately, last very long in terms of its protection against infection. This is just a reality that we faced for more than a year now in terms of how we understand vaccines. Their most important function isn't to protect you from infection. Their most important function is to protect you from having hospitalization or death. They are maintaining that ability. And so we're seeing that individuals with 3 or more vaccine doses or 4 doses are still being more protected from individuals who have not been vaccinated. That remains the case, particularly in the elderly population. So whichever vaccine is available to you now, whether it's a bivalent or not, that still will have the likely effect, especially people who are more vulnerable.
And I just wanted to clarify, because there were some early studies I read, perhaps small, but that indicated that the bivalent did not produce an improved antibody response. What's your take on its efficacy versus the original?
I think it's probably going to have some small added benefit, but it's not going to be dramatic. And we're always going to have this limitation, whether it's a bivalent or an updated vaccine that comes after that it's not going to, the effect is still not going to last long. These antibodies that are generated from a vaccine are not going to be long lasting. So unfortunately, the best available evidence now suggests that probably at 3 months, your risk of picking up the virus is almost back to baseline. Your risk against protecting you from death is still quite good if you've been vaccinated, but just from plain old infection, picking up the virus or transmitting it to others, unfortunately, that effect, probably in the range of 3 to 6 months, is already gone. Even infection, the same kind of thing applies, perhaps a little bit longer. If you've been infected by COVID, your protection, unfortunately, doesn't last long either, perhaps somewhere in that same range, maybe longer. So that's important to remember that there is going to be limitations in the available vaccines right now.
So would you advise take the bivalent over the original vaccine, or if you have a choice, or take whatever is available?
Exactly. I would take whatever is available. The difference isn't likely to be substantial at this stage. The most important thing is that you do get a vaccine. And really, the most important thing is that the most vulnerable people get the vaccine. That's really where the messaging should be most focused on. We know that individuals 65 and older, and to some degree 50 and older, are at the highest risk of developing severe consequences from COVID. That's still true today as it was previously in previous strains. Although it's true that the overall mortality has dropped, still the relative risk is higher in that group. Same applies for individuals who are immunocompromised, for example, transplant or oncology patients. So for those groups of people, that's where it's really more important to get boosted compared to the general population.
And what's the guidance right now, Alon, in terms of recommended intervals for your booster shot?
The National Advisory Council on Immunization generally recommends 6 months be the interval between boosters or between infection and booster. However, they recognize that many people are going to want to get a vaccine sooner for various reasons. And so the minimum interval is 3 months. So for most individuals, somewhere between 3 and 6 months is probably reasonable. And if you're not at particularly high risk, then you could certainly wait 6 months. When you vaccinate sooner rather than later, you're probably exchanging some short-term immunity for long-term immunity. But again, with COVID, it's unfortunately not going to last as long as we had hoped for.
And I'm curious, how are we doing with vaccine and booster uptake in Ontario today versus where we maybe should be?
That's an excellent question. With the overall 2 doses, we're probably around in the mid 80s around this period in Ontario. So individuals getting at least 2 doses is around 85, 86%. Individuals getting a 3rd dose is closer to 50%, maybe around 55%. And then people who got 4th doses is much, much lower. So in the 20, 25% range. But the people who really should get the 4th doses are the people who we talked about earlier who are at high risk of bad outcomes. So really, again, the messaging, most important thing for those people to get the booster, if you haven't got your 3rd dose, is those individuals who are older. After the 4th dose, we don't know really what the next steps and advice is going to be. Obviously, we can't be vaccinating people every 3 months or every 6 months. It's just not a sustainable approach for the majority of the population. So at some point, we're going to settle out in terms of what the regular interval is for COVID vaccination. And this will depend on the seasonality of COVID and how severe it is and which population group you're on.
All right. So as we enter holiday season, what is your guidance in terms of lowering risk for infection, at indoor gatherings, going shopping at the mall, going to big events?
I think the recommendations are generally very similar as it's been over the last few months, recognizing that COVID is not as deadly as it used to be. So if that is your main concern, you should make your decisions based on that information. For example, the overall case fatality rate from COVID in January of last year was around 4 to 5%. Now we're closer to 2%. This may inform your decision making around whether you want to go for holiday events, whether you want to go to larger gatherings with your family in outdoor places. The minimum you could decide to do in public spaces is masking in indoor settings if you remain concerned. In terms of family gatherings, there's a lot to consider here. Obviously, the fact that gatherings have been minimized over the last 2 years, this is, of course, very important to many, many cultures celebrate many, many holidays around this time of year. So, and certainly flu and RSV are back and more likely to cause infections this time of year. So I think everyone has to make their own decision, but certainly masking is one of the basic ways you can try to improve your protection. Ventilation has always been an important aspect to preventing COVID transmission. Similarly, it's likely going to be beneficial in protecting you against flu and RSV as well. So the same kind of principles we've talked about in the past, whatever you can be doing, being in open spaces, opening windows wherever possible, not going if you're symptomatic, rat testing if you're symptomatic, those kinds of principles still applies. But again, recognizing that things are not quite as bad as they were in previous years.
And in terms of rapid tests, if you're starting to feel symptoms, how accurate are these rapid tests in confirming we have the virus?
So as the Omicron waves continue to come upon us and we have more and more variants, more and more mutations, it's likely that it's not going to be as sensitive. However, the rat tests do remain quite specific. In other words, if you test positive, it is highly likely you have COVID. If the rat test is negative, then there might be some concern about you not testing positive, in other words, a false negative. I would say the same advice applies there too. If you have symptoms and you continue to have them or they're worsening, you could always do a 2nd or a 3rd rat test. Of course, you are very sick, you should just go straight to hospital and they'll do a PCR test for you. But if you're at home, you could always do a 1st or 2nd test. The important thing to recognize now is that whereas December of 2021 or January 2022, you had symptoms, COVID was by far the most likely thing you could have had, and the rat test could have been negative just by its limitations. Now, if you test negative on the rat, there's more chance that you actually have some other virus because there's a lot more circulating. So you have flu, you have RSV, could certainly be the case. The bottom line is that the management is the same in most cases, which is until you're feeling better, you shouldn't be exposing other people to the best of your abilities. So if you're feeling unwell, your rat test is negative, you probably have flu or RSV or some other virus, you should still stay home and avoid exposing yourself to other people.
And again, probably good to remind people, what are the recommendations or guidance in terms of isolation?
So with flu and RSV, it's very similar in that for the most part, as long as you're symptomatic, you should try to isolate. And this was the recommendation before the pandemic. It was never mandatory. Public health messaging wasn't as prominent as it is now, but that was essentially the same as it is now. For COVID, the most likely period where you're going to transmit to somebody is when you're symptomatic. On average, that's 5 days. So this is not required as the same way it was previously in the pandemic, and the same is true across all provinces in Canada now. But if you have symptoms and you confirm you have COVID, about 5 days is a reasonable time to be isolated before you return to work. Or other places may have different policies, of course. In UHN, we have our own policies. If you're in a hospital setting, that's different, but 5 days would be the average period.
And on the COVID-19 treatment front, I understand availability and efficacy of Paxlovid was in the news again the other day because of its being available now through pharmacists. Talk to us about that.
Yes. So unlike flu or RSV, we have medications that high-risk individuals can take if they are still outpatients to prevent them from progressing to a more severe illness. Paxlovid is one of those medications that is widely available here in Ontario. Another one is remdesivir, which is intravenous. But Paxlovid, a pill, it was widely available in Ontario for several months. It was restricted to certain individuals who are high risk, where the evidence is most strong to support the benefit. It used to be that you needed a prescription from a physician or a physician involvement for you to get the medication. Now the steps have been taken in order to allow pharmacists to make that decision without a prescription, without the involvement of a physician, which makes sense because pharmacists are usually intimately aware of the patient's medication history and their medical conditions. Plus, pharmacists are more widely available, spread through the community, and they may even provide rapid testing for patients as well. So it goes hand in hand. If you rapid test through a pharmacy and the pharmacy has the medication available, they can provide it now. And again, this medication is most beneficial only in high-risk individuals.
If we needed any further incentive in terms of preventing, getting sick in terms of COVID, I've been reading about mounting evidence of a number of long-term health effects after getting the virus, everything from higher risk of stroke and cardiovascular disease to lower T cell counts, even lower sperm count in men. Do we know yet what it is about this coronavirus that's causing so many long-term health effects?
That's an excellent question. And this question of long-term effects is constantly being studied now because of so many people being infected and so many people reporting symptoms. We know that COVID, when it infects you, causes a severe inflammatory response in some people. And that could be the explanation for why we're seeing these long-term side effects at some degree of inflammation, perhaps in the vessels of the blood, or perhaps in the brain or the heart or other organs. The other thing we do know about the COVID long-term side effects is, for one, vaccination significantly reduces your risk of developing side effects in the long term. Secondly, we know that in children who do have long-term side effects, the vast majority of them have a resolution of their symptoms within a year after having them. And third, we know that the probability is probably a little bit lower than what's currently estimated. And that's partly to do because this is quite early in the research. So when people are estimating this, they're basing on 6 month or 12-month follow-ups. But perhaps we're going to see fewer and fewer as the months go on, as the years go on, when we do more and more follow-ups with more controls, for example. There was probably some degree of long-term side effects associated with flu and other respiratory viruses, and some of it's in the literature from the 80s, for example. It just wasn't as well studied as COVID. But because so many people are infected by COVID, because there's so much resources and stuff being invested into studying this, we have so much more knowledge about the long-term side effects of COVID compared to other viruses. So there's still a lot yet to be answered about these long-term side effects.
So I'm just curious then, though, as a physician, would it be useful now if you've had the virus, if you've gotten COVID and you're going to your GP, your family physician, should we start saying to them, I've had the virus?
You could certainly tell them. I think it's always important to let your physicians or other clinical care teams to know that you've had your past medical history. It's part of it that you've had COVID. I think it's particularly important if you've had a severe infection. In other words, you were admitted to the ICU. Those are the individuals more likely to experience long-term consequences, not only related to COVID, but the very fact they were admitted to ICU. We know that's associated with many sequelae. So if you feel that it's related to a symptom you've had, certainly you can report it. Just recognizing that millions of Ontarians now have had COVID, and many of them do not experience long-term side effects. So it's important not to have a early diagnostic closure and focus on COVID as the cause of your symptoms. More likely that it is something else. But of course, it's always important to discuss those things with your physician who knows you best.
Good point. Okay, big picture, I read where the World Health Organization is monitoring up to 300 variants of the coronavirus, including an emerging new variant of concern called Pi, and that these new ones are getting better at infecting and spreading. What are the implications of this over the next 6 months, 12 months?
That's the million-dollar question: is what's the future of COVID? The best answer we can give is based on what the recent history of COVID is. So if we just look at Omicron from January until now, the last 12 months, what we've seen is new variants show up that have been progressively, to some degree, more transmissible, but to some degree also less deadly. So if that trend continues and new variants develop, then that's probably going to be the outcome here. So if we just continue seeing the current trend, we're just going to see more and more infections and less deaths associated with COVID. That seems to be the case over the last few months, but we can't say. There may be a variant that shows up out of the blue that turns out to be more transmissible and more deadly that we couldn't predict. So it certainly could happen, but the experience of the last year tells us that that's not the case. So all we can do is monitor closely, to get vaccinated, and to keep an eye for symptoms if you do develop them. But hopefully we don't see some kind of anomaly show up that results in more people getting infected and dying from COVID.
Yeah, I guess, last question here. I think probably a lot of people are frustrated. We're coming up on 3 years of the pandemic, and to many, I'm sure it seems like we're moving. If we're not moving, it's certainly, there's doesn't seem to be a direction that we're moving in terms of, has anyone identified what the path is to terminating the pandemic?
Yeah, I sympathize. You can certainly look at the situation now and say to yourself, how are we any different than we were a year or 2 years ago? The most important thing I could say to you is that the case fatality rate has dropped dramatically. That is the single most important thing to recognize about COVID. Based on the Ontario data that they report, 30% of people who had COVID in Ontario, there's a lot of limitations in this, died based on their data from the earliest wave of COVID back in March 2020. Now we're down around 2%. So that is a substantial difference. Not only that, but we know that a lot of people have gotten COVID over this province over the last 12 months and not suffered severe consequences as a result. So there is the reality that, for better or for worse, Omicron showed up, caused a ton of infections. Unfortunately, people died. And now we're at the point where the mortality rate has dropped. And so that is a substantial difference compared to before. And we see the difference in the way we're managing things. The more hospitalizations for COVID are far fewer than they were before. As an example, if you look at our ICU here at UHN, specialized in management of COVID, far fewer people here are admitted because of COVID pneumonia. A lot of patients here are admitted incidentally with COVID, perhaps to some degree precipitating a chronic illness. But that disease of COVID pneumonia that was killing so many people, that entity is far dropped. In terms of the proportions, significantly dropped compared to previous years. And so we see things have changed, right? We see that society has opened up. We've, sporting events, bars, restaurants, Christmas events, all these things are back on now. And I don't believe that those things are done in a way that's negligent or harmful. I think to some degree, those things are necessary and important to continue, with the caveats that vaccination remains important, early access to therapeutics remains important, getting sick leave for people who need to have sick leave. All those things remain important to protect us.
Absolutely. All right. Let's get to our audience question, Dr. Vaisman, and we'll do our best to get to as many as possible. First question: cases and deaths from COVID are not being reported in the news regularly at this time. What is the percentage of cases and deaths at this time? Are vaccinated older people still at high risk, or if they have had all 5 vaccines, or are the number of deaths low? You sort of mentioned deaths, but I'm curious about vaccinated older people still at high risk.
Yeah, the risk for vaccinated older individuals has dropped dramatically. So the proportions of those individuals having significant hospitalizations or deaths is very, very low compared to before. And this individual is asking about case counts. Those are reported, but they're not as readily reported in the media. But if you wanted to go online and look, you just have to Google Public Health Ontario Lab, weekly COVID report, and there you'll have everything. Or the data tool, the Ontario Health COVID data tool. And there it'll tell you exactly what's going on in Ontario based on the available COVID testing. So the number of hospitalizations, ICU admissions, the deaths per age, the deaths based on vaccination status. So, and to some degree, I think it's a good thing that media doesn't constantly report the numbers anymore, but it's all publicly available and you can certainly go there and look and judge for yourself. And you'll see that pattern I was discussing earlier about the up and down waves that we've been experiencing since April. So still vaccination remains important to this person's point about dropping the mortality rate. And of course, we encourage those high-risk people to continue to do so.
Next question. As I go to various venues, restaurants, stores, I notice the vast majority of people are no longer wearing masks. With 3 viruses circulating at the same time, isn't this a recipe for disaster? Are you and your colleagues recommending an indoor mask mandate to limit their spread during the winter?
It's a very, very good question. I think nobody doubts the importance of having mask mandates in high-risk settings such as hospitals or long-term care facilities where vulnerable people are there and we want to protect them. There's no doubt about that. We're going to continue masking here, for example, at UHN for the foreseeable future. As for the public settings, I think it's important for people to recognize the difference between a mask mandate and the public health recommendation to mask. I do agree that for the most part, it makes sense to mask in indoor settings, especially where there's people are in tight spaces, not able to distance from one another, which is probably more important for flu and RSV now in terms of the numbers that we're seeing. But it's important to recognize that if we try to mandate masks at this point, it may not have the impact that we would have expected as it did in previous years for many, many reasons in terms of the backlash, the social acceptability. We're not talking about people at the extremes of anti-mask or anti-vax. We're talking about the majority of the population simply isn't as interested in doing it as before. And public health has a certain amount of capital they can spend in terms of trying to convince the public of doing things. And, you have to think about what the punitive measures are going to be. So although I do recommend masking in general, I'm not sure I support a mandate in the same way that I would have supported in previous years when it was probably more impactful.
Can being cautious, and thereby not having exposure to viruses and colds actually negatively impact our immune systems because they don't get a chance to naturally build up immunity? Haven't even had a cold in close to 3 years now.
Yes, this is an excellent question. It goes back to your question about immunity debt. Does immunity debt apply to an individual such that if your immune system hasn't been exposed to things, does it weaken? As far as we know, that's not an accurate representation of what the immune system is like. It's not like the same as a muscle that needs to be worked out so that it responds better in case of a stress. If you would have to some degree, if you've been exposed to a virus now or 3 years ago, you may to some degree would have had the same response in terms of severity, whether it was mild or strong. The immunity debt thing, again, as I mentioned, is probably more important on a population level. What they're describing here in terms of timing of an infection or timing exposure may be more applicable to young children. There may be something to that where a certain age of an exposure to a virus may be more protective than other ages. This is still yet to be determined, and research is going into this to figure out why we are where we are right now. But it doesn't imply, for example, that we should be intentionally exposing anyone to viruses. And still the recommendation, of course, is that everyone from babies to elderly individuals should do our best to always avoid picking up infection, whether it's virus or otherwise. There's no real benefit to intentionally getting infected by anything at any point. So regardless of the reasons why we're here in terms of the RSV flu numbers, we should always try to avoid infection.
Question from JJ. Are there tests that determine if one has ever gotten COVID-19 and or long COVID? If so, what are the tests and where can you get them? If not, then why not?
So for long COVID, there's no specific diagnostic test you can make. It's a constellation of symptoms associated with a recent infection. So certain symptoms meet a criteria, and then plus an infection, that's where the diagnosis is made. In terms of have you ever had COVID, there are antibody tests you can take. So you can check for specific antibodies in your blood to tell you whether you've been exposed to COVID at any point in your life. and also tests you can check whether you've been exposed to a vaccine. These are not widely available because it doesn't really change the clinical management. So we don't need doctors, nurses, we don't really need to order this test because it doesn't change anything for our patients. But if you're interested in knowing, you could always sign up for one of many clinical studies looking at COVID exposure here at UHN or other sites across Canada. And part of those protocols sometimes include checking your blood for an antibody to check if you've had COVID in your lifetime. And you'll be, of course, be told about the results, and that's probably the best way for you to get that done. You could also go online and get a test done that way. I mean, there's plenty of tests that you could pay for online. You can order off Amazon, for example, or from America, and you can do it that way as well. But there may be differences in accuracy and reliability there. So you have to do your research if you want to do that.
Next question. I'm 79 and have the 5th booster for COVID-19. Do you think further boosters will occur every 3 months or will it be annually?
Excellent question. We don't know really at this stage. Even for 5th doses, there isn't as much evidence to know what exactly the effect is in terms of its protection. So we don't know what the next steps are going to be in terms of vaccination. Currently, the national guidelines for Canada, again, recommend a booster at every 6 months or 3 months at the earliest. But that's the recommendation that was put out during the fall of 2022 in anticipation of more COVID waves. What's it going to look like between January and July of 2023? Are we going to need more boosters? Only time will tell. Presumably, there is a reduction in the benefit you get with more and more boosters. The core of the evidence that we know for sure is that 2, and especially 3 in elderly people, offer a high degree of protection against death. But beyond that, 4 or 5, there's less and less evidence to know. Perhaps the answer will come when we have more randomized trials or we have more experience in upcoming winter seasons. But at this time, we don't know whether, it seems unlikely that every 3 months will be recommended. That seems an unsustainable approach, but we'll see.
Very useful. Next question. Can you address any new vaccine or treatment efforts that you are aware of, say nasal vaccines, updated mRNA vaccine, new monoclonal antibodies? It looks like governments have given up on supporting new interventions in the day of warp speed or in the past.
Yep, that's a great insight, is that to some degree that interest among governments around the world about investing in new COVID therapeutics or protection certainly has dropped off. And to some degree, it's because many people in their population already got COVID. And again, the mortality rate has dropped. There are new developments in nasal vaccines being developed outside of Canada, which we could see soon here in Canada in terms of large-scale randomized trials being done. In terms of updated mRNA vax, the next wave will be probably outside of COVID, and for RSV and flu, for example, getting mRNA vaccinations for those. So whether those can be, so for RSV, for example, we don't have a vaccine for RSV. So a novel mRNA vaccine may be helpful there to protect people against RSV. So that is the next steps in terms of mRNA vaccination, is non-COVID vaccination. In terms of new monoclonal antibodies, that's probably something we're not going to be looking into for a while, or perhaps not going to be widely available. And the reason is that over the last 12 months, the monoclonal antibodies that have been available are just more and more ineffective at protecting us against COVID. Because the mutations are constantly changing, we are just fighting a losing battle developing new monoclonal antibodies. So for example, Evusheld, which was used as a prophylaxis against COVID, that's no longer very effective, and it's no longer being supported by the government. So it's not likely that monoclonal antibodies are the future of COVID management.
Next question. What do you recommend for family indoor gatherings at this time of year? Should these be avoided altogether to stay safe?
I'd say for the most part, you shouldn't avoid them altogether, unless you're in some kind of exceptional circumstance where there's an individual who is highly immunocompromised, undergoing some kind of transplant or chemotherapy, who's very, very susceptible. But even still, there's many individuals who are going through chemotherapy who are not in their most immunocompromised state, for example, just after having a bone marrow transplant. Even those individuals, they could still gather. It's just a matter of being safe. If you don't have any individuals in your family who are exceptionally immunocompromised, I wouldn't say you need to avoid family gatherings. I think you could take a few safety measures, as we discussed, not coming together if you're ill, testing if necessary, improving your ventilation if that's an option for your household. But I'd say at this stage, we should try to encourage people to get together for holidays with the understanding of the risks and benefits. I think people can have do now have the tools to make those decisions for themselves.
Good advice. Can someone be an asymptomatic carrier of COVID-19, RSV, or other viruses currently circulating? Is it rare?
Yeah, for COVID, it's certainly common for people to have asymptomatic carriage. And the ranges here estimate quite broadly. Some are 20, 30, 40% of people might have had COVID and not know about it. Some studies show even up to 50% of people who have had COVID don't even know they've had it. So, and to some degree, those patients can also transmit to others. With RSV and other respiratory viruses, it's thought to be less common. We think that with flu, RSV, and other respiratory viruses like human metapneumovirus or parainfluenza or other cold viruses like other rare or common coronaviruses, it's less common for people to be asymptomatic. So to be a carrier, it's not the same kind of way we think about it with other respiratory viruses. You're more likely to develop symptoms, in which case you should try to protect others and try to isolate yourself.
A long COVID question for you. A new Swedish research company, Novus, estimates 14% of the country's adult population suffers from long COVID. US Census data suggests 7.5% of adult Americans experience long COVID. Can you comment as to whether Canada may be looking at similar numbers based on your observations at UHN?
It's a good question. We don't have as firm numbers here in Canada. I'm not, as far as I know, we don't have a large population-based study here in Canada to estimate that number, but I think that those numbers are probably higher than what will end up bearing out with the further studies that are done. For one thing, we know that many people who've had COVID, as I mentioned, don't even know they've had it. And a lot of people have mild, very, very mild infections of COVID. So it's quite unlikely that mild infections lead to very long course of illness. I think that those numbers are probably more applicable to people who've had more severe forms of COVID or more severe infections. And it seems to me just that it's likely to be an estimation, but again, I'm open to hearing and reading about new studies. We'll see how this bears out. I think it's a little bit early to know what these numbers mean in terms of what is the long-term complications and what does it actually mean for their long-term health.
Next question. Has there been any new research re odds of developing long COVID? COVID is no longer quite the risk it once was if vaccinated, but the threat of long COVID is scary. It would be great to know the newest numbers as far as percentage of people who go on to develop coronary, neurological, and other issues.
Yeah, this is very similar to the previous question. It gets at what is the actual proportion of people who develop long COVID? And again, there's been a very, very wide estimate of ranges. In that previous question, you saw 7 to 14%. There's other studies that suggest 1 to 5%. The important thing is that what we can do to protect ourselves really is vaccination. That's one of the most important things you can do to reduce your likelihood to develop long-term consequences associated with COVID. We know that with 2 doses, the risk dramatically falls. And we know with children, for example, having a vaccination also reduces, especially older in the teenage years, reduces the likelihood of inflammatory disorders associated with COVID. So most important thing we could do is to get vaccinated. Unfortunately, we have to wait a little bit longer to have a better sense of what the proportions might be of developing long COVID.
Question from Judy. If you choose to travel, is it wise to ask your doctor for an antibiotic prescription prior to travel?
In terms of COVID, RSV, and flu, it's not likely that you'll require antibiotic prescription. One important distinction that we didn't talk about between the three is that unlike with COVID, having a bacterial infection after having flu or with flu is more common with influenza than it is with COVID. With COVID, it's actually quite rare and uncommon for you to have a coexisting bacterial infection, which is what antibiotics are for. So keep in mind that antibiotics don't treat flu, RSV, or COVID. Antibiotics are antibacterials that treat bacterial infections, which can occur with influenza. For example, lung infections can occur after you've had influenza or when you've had influenza. So unless you are an exceptionally high-risk individual, you don't need an antibiotic prescription to go with you. So if you have some condition that predisposes you to bacterial infections, you could look into that. But for the average person, that's not necessary.
Next question. Is there a downside to wearing a mask? For example, would I be more vulnerable to other viruses that are circulating when exposed?
That's a good question. Similar to the previous question about the immunity debt, there is no downside to wearing a mask with regards to your exposure to other viruses. We should, again, try to avoid pickup viruses. And if you choose to wear a mask, you will not experience negative side effects from that perspective. You could absolutely continue wearing a mask and not worry about that. There are no, generally speaking, long-term health side effects associated with masks. It's really individual. In rare instances, some people can simply not tolerate a mask, but the vast majority of people can. They could breathe just fine. So there really isn't much of a downside to wearing a mask aside from the cost and some minimal discomfort in the majority of people.
More on masks here. Next question. Elastomeric masks appear to be the next level of safety in public environments. Can you make recommendations on what to look for with these masks?
So elastomerics are, the audience may not be familiar, but these are masks that look like what paint people use during paint spray, or like on the street when they're doing spraying of a paint on the sidewalk or something. They're very large. They almost look like a gas mask. They have two large outports coming out of their mouth. I would say that this is quite unnecessary for the general public. There isn't really any good reason to be using these whatsoever. First of all, the added protection that it may provide you compared to a baseline mask or N95, for example, is negligible and not really relevant when it comes to public settings. Secondly, they need to be very meticulously cleaned. So there's certain protocols on how to take them off and clean them. Third, a lot of them only have one-way valves that only protect the individual but don't protect others. In other words, when they breathe out, if they have an infection, you might expose other people. So we try to protect, if you want to wear a mask, it's a good idea to protect yourself and to protect others from you as well. So, and they're also quite uncomfortable. You also don't have full head rotation when you use them, and they're expensive. So many, many reasons why I would not recommend anyone to wear these elastomeric masks in public.
Next question. Is it possible for a COVID virus to combine itself with a flu virus and create a new mutation?
That's, never say never, but there is a paper that came out in Science that proposed potentially this occurring in a laboratory setting. But I could say that as far as we know in the clinical setting, this has not occurred. Maybe it's something we'll see down the road, but it seems quite unlikely. The flu virus and COVID virus are not within the same family of viruses, so their genetic makeup is quite different from one another. What they have in common is the symptoms they cause in people and the fact that they cause upper and lower respiratory tract infections. But outside of that, their genetics is not similar. And it seems to me quite unlikely that such a combination would occur. But again, never say never when it comes to infectious disease.
Certainly, we've learned that the last couple of years. Next question from Barry. I'm a mother living in a multi-generational home with young adult children with active social lives and a 98-year-old mother. How can we keep her as safe as possible while navigating this new normal? We're all vaccinated. Should we wear masks, maintain our distance from her at home?
I wouldn't say that you need to routinely wear masks or distance, but especially with flu and RSV being more common now and other viruses, if you are sick, it makes sense to distance and to wear masks. If you're feeling fine, if everyone's feeling fine around your grandmother, around an elderly individual, you don't need to routinely do those things. It's important for elderly individuals, of course, to have social contact. And the most important people is the family, of course. So, keeping distance is not something you want to do with somebody who's elderly, especially with elderly individuals who may develop cognitive impairment or have already developed cognitive impairment. So outside of that, it's really the common sense things. Wear a mask if you're sick, or distance altogether, or not come in contact when the times that you're sick. Make sure your vaccines are updated. Vaccinating the younger people in the house is a very important way to protect the elderly individuals. Even vaccinating a 2-year-old against flu can protect a 98-year-old from picking up flu. So everyone in the house should get their vaccines updated. RSV, we don't have a vaccine. Flu, we do. And of course, COVID, we do. And then, of course, washing hands and maintaining proper hygiene is another important thing. With COVID, hand hygiene and surface transmission are not as important. With flu and RSV, they are thought to be more important. So hand hygiene becomes more important with those two viruses. Very important that you maintain that in the household.
Next question. Can COVID-19 or long-term COVID-19 affect certain heart arrhythmias, specifically atrial fibrillation? If so, what is the effect?
So certainly acute COVID infection can cause a whole variety of cardiac manifestations. If somebody's very acutely unwell, just like with other infections, COVID-19 can precipitate arrhythmias like atrial fibrillation, for example. That is usually in a person who's already susceptible to developing arrhythmias. If somebody's critically unwell, just like with other infections, COVID-19 can precipitate that. In terms of long-term COVID, again, this is an area that's probably less understood, is what is the effect of having long-term consequences on the heart, particularly having an arrhythmia like atrial fibrillation. We don't quite know. Presumably there may be some impact in a small group of people, but the largest or the majority of people will not develop, that's for sure. The vast majority of people will not develop atrial fibrillation after having been infected with COVID. But, this is something, again, that remains to be seen exactly how small or how big that risk is.
What do we know about the effect on babies born from women who had COVID while pregnant?
So in general, we don't know as much in that group of patients. It's generally a small group of patients who've had babies during the time that they had COVID. Getting COVID when you are a baby is the most important side effect or consequence that you want to avoid, transmitting from mom to baby. So we know that infants can get COVID and can have bad outcomes. If the baby is born before the time that the mom can transmit to the baby, in other words, when the mom is breastfeeding or holding the baby, then as far as we know, there isn't any specific consequences in terms of COVID infection in the baby, but there are consequences for mom, and therefore that affects baby. So for example, if the mom during pregnancy becomes severely unwell and has a COVID infection, that can certainly have effect on the baby. When moms get severely unwell for whatever reason, including infections, that can sometimes lead to fetal demise. We're talking about very severe infections in general, but very important that we protect moms against all sorts of respiratory viruses, including flu and RSV with vaccination and therapeutics as well if they do get infected. That is the most important thing to consider, is if mom gets severely unwell due to COVID, and that could have very negative consequences on baby.
Last question. What can be done to get better access to the COVID-19 bivalent or a second vaccine for children? BC has access outside the schools to address this issue. Can anything be done here in Toronto?
That's a very good question. I'm not as familiar in terms of getting access for COVID-19 for a vaccination for children. The most common sites where COVID-19 vaccination is available is family physicians' offices, pediatricians' offices, and hospitals. So, for example, a hospital for sick children or other hospitals that looked after kids. Outside of that, there aren't as many COVID vaccine clinics like there were a year ago. There's very few to my understanding, and there's not as much of a push to set up these mobile units either to get kids vaccinated as there was a year ago. So I think the best bet for any individual here is to speak to their family doctor, their pediatrician, or to go to a hospital, an outpatient clinic in a hospital where vaccination is available.
All right, we've come to the end of our questions today. To all of you out there watching, thanks so much for joining us, and to our terrific new guest, or to our terrific guest, Dr. Alon Vaisman, UHN infection protection and control physician. Thanks so much for taking time out of your day and your busy schedule to share your insights and expertise, Alon.
Thank you for having me.
This live stream will be available for viewing on the UHN Foundation Facebook and YouTube page. And finally, donor support. Your dollars fuel the groundbreaking research initiatives of our award-winning UHN scientists. So if this pioneering work interests you and you'd like to support it, please consider donating. You would go to www.uhnfoundation.ca/help. Thanks for tuning in, everyone. We'll be back soon with another episode. Keep an eye on your email inbox for details. In the meantime, be kind, practice physical distancing, mask up, get your booster vaccine, and stay safe. Have a restful and happy holiday season, everyone. We'll see you again.